Hello, everyone. We're going to get started in just a minute, so if you could find your seats, that would be great. I said this earlier, but we have a problem with the show tonight. So if anybody, we sold too many tickets. We have some options, so it's a good problem to have. If anybody would like to volunteer, we're looking for 22 people to go to the 9:30 show. If anybody would like to volunteer to go to the 9:30 show, follow me out. And we'll make that happen, and we'll figure out transportation. All that will be a piece of cake, or you can go with the same group and have dinner before the show. So that's an option. The other thing is because the last time I announced this, not one person followed me out. We may have a problem. So we are now also looking for 22 people, if nobody wants to change, for 22 people that want their money back and want to do something else. So keep that in mind. So you have a couple options. You can either have your money back, or you can go to the 9:30 show, and if we don't get volunteers for one of the two of those, I have absolutely no idea what we're going to do at that point. But yeah, throw them off the plane. We're going to have to throw some people off the plane. But what's that? Have a dance-off? If you don't volunteer, you will be dancing. Dr. Gorniak, the chief medical examiner in Atlanta, Georgia, is going to come up here and start a dance-off to decide who is going to go to the show. She's a good dancer, though, so she's going to the show, I can tell you that. So, again, we're going to wait a couple minutes because there's some people filtering in, and if anybody would like their money back or to go to the 9:30 show, please come and see me. And we may be desperate at this point, so we'll beg if we have to. Lauren, this part isn't being broadcast on your website, is it? Oh, well, for those people on the internet, thank you for being here. And we're going to get started in just a minute. Like probably right now.
Good afternoon. Welcome back, and thanks for coming back from lunch. Hopefully we can keep you awake this afternoon. Just so you guys all know, sessions this afternoon are actually going to be broadcasting live. We have an audience of about 100 people out on the internet that will be also listening to this feed. So keep that in mind if you do ask questions. We'll try to block out your questions, and the speakers will repeat them. But do know we are being live broadcast. So that's just something to be aware of if you're talking about sensitive information. And with that, it is my pleasure to introduce Dr. Jim Caruso. Dr. Caruso was born in Chicago and obtained his undergraduate and medical training at the University of Illinois. Prior to entering medical school, he embarked on what would be nearly a 30-year career as a Navy medical officer. Dr. Caruso completed anatomic and clinical pathology training at Duke University Medical Center, where he served as chief resident and also as a fellow in hyperbaric and diving medicine. His forensic pathology fellowship was at a combined program with the Office of the Chief Medical Examiner for Maryland and the Armed Forces Institute of Pathology. Dr. Caruso subsequently served as the Chief Deputy Armed Forces Medical Examiner and Regional Armed Forces Medical Examiner for the Pacific and Asia. He completed formal training as a Navy Undersea Medical Officer and Navy Flight Surgeon during his military career. After retiring as a Navy captain, Dr. Caruso was appointed the Chief Medical Examiner and Coroner for Denver, Colorado. He has a particular interest and expertise in water-related deaths and has numerous first author publications and presentations to his credit. And he's going to be talking to us about how cannabinoids affected his community. Dr. Caruso?
Okay. Thanks, Kelly. So we have 90 minutes together. I'm not sure I'll fill the entire 90 minutes, but that probably won't disappoint some of you to get done a little bit early, but we'll also have some time for questions. As Kelly said, I took over as Chief Medical Examiner in Denver in January of 2014. Something else happened in January of 2014. Colorado legalized recreational marijuana. Coincidence? Yeah, actually it is a coincidence that I happened to show up at that time. But and I go to a lot of national meetings, and many of you probably do as well, the Academy, NAME, and then also the Colorado Coroners Association meetings that we have. And everybody always asks, well, what is marijuana doing to your practice? What are you getting all kinds of marijuana-related deaths, and it must really be changing your workload? And the answer is, no, not really. I'm going to show you and tell you a little bit about how legalized marijuana has affected forensics in Denver and in Colorado, but the real take-home message is that there's a lot of correlation and not a lot of causation. So we always set out with some objectives, and this is my goal for the next, I don't know, 80, 70 minutes, something like that. I'm going to tell you a little bit about the history of marijuana, the initial criminalization of marijuana, and then move into how it became decriminalized, and then medical usage, and finally legalized for recreational use. I'm going to tell you specifically about what happened in Colorado and how it all came about. It all happened before I arrived, of course, but there's a pretty good paper trail on how this all came about. I'm also going to tell you a little bit about the pharmacology of cannabinoids, and some of it's going to be a little bit dry because it is pharmacology, but for anybody who is in the death investigation business, you do need to know a bit about toxicology, even if it's just being able to look at a tox report and kind of give some insight to the family, or if you're a pathologist, you obviously have to incorporate it into your autopsy report and really be able to determine what the toxicologist is telling you. Then I'm going to show you some data that we've accumulated over the past 4 or 5 years as far as what cases are coming in with positive toxicology for cannabinoids. We actually went through and divided them by manner of death. There's also some specific pediatric issues. My clinical colleagues are besieged with ER visits and hospitalizations for minors who end up under their care for essentially what is either an overdose or sometimes an idiosyncratic reaction to cannabinoids. Now, you typically can't, at least an adult, overdose on marijuana and kill yourself. You can do dumb things while you're impaired, and that's usually how they end up in my office. When it comes to kids, a little bit different, and I'll tell you the story about what our children's hospital is seeing. Then I'm going to introduce Cannabinoid Hyperemesis Syndrome. How many have heard of that? So only a couple. Okay. It's out there. We've had a few deaths in Colorado, and there's some publications out there. So that's kind of an interesting subtopic, and we'll talk about that towards the second half of the lecture. And then I'm going to give you some relevant cases from Denver where I think cannabinoids either directly or made a real indirect impact on the outcome. So Denver is the Mile High City. It's beautiful. I was attracted to Colorado because I spent 30 years in the Navy, as Kelly had said, and in the Navy you never get to go to the Rockies. You're on the East Coast or the West Coast or overseas or something, and landing in Colorado was fortuitous. The job was open, and I took over in January 2014. And we'll talk about cannabis for the next hour and a half, as it were, but there's a lot of different names that go along with it. Cannabis is just an overall general term, and cannabinoids is a group of drugs, but there are actual genus species associations with the plants that these cannabinoids come from, and as you can see from the slide, those are the three most popular. The most popular is Cannabis sativa, but there are others. The chemicals that we're interested in are tetrahydrocannabinol is the main one, THC, and people interchange that with just marijuana, but actually that's the chemical drug of concern. There are also metabolites of that, inactive and active, and we'll talk about that a little bit. And there's a lot of other cannabinoids. That's just the one that is most concerned with recreational use. But I'm sure most of you are aware that there's a lot of popular movement towards using cannabinoids for medical therapy. And some of them are related to THC, but they're not THC. They're other cannabinoids that are in the plant. And the goal for use for many of those indications is to separate out the THC from the other cannabinoids and purify the other cannabinoids and use them medicinally because they tend not to have some of the effects that THC has. And that's where the medical situation is at. And we'll go into medical marijuana use here in just a couple minutes. Lots of different ways of using cannabinoids. Smoking is probably the most popular, and vaping is a type of smoking. You can now put either the liquid or wax in a vape pen, and you can use marijuana that way. Anybody who's been to a concert almost anywhere in the country, legal or not, has probably encountered that. People vape and, kind of, they hide from security a little bit better that way, although I'm not so sure. Sometimes you see the big cloud going up over the top and you wonder how that's hiding. But there's a lot of different terms that have been used for marijuana over the years. I think pot and weed are still in vogue. Some of the others are really, really outdated. Nobody says dope anymore. If you're in Jamaica, they still say ganja. But there's a lot of different terminology that goes along with marijuana. Hash is also a marijuana, basically a marijuana product, but much more concentrated. And what they're doing in Colorado and other places around the country now is actually making hash oil. And in some instances, that has caused fires and explosions that rival what we were seeing with methamphetamine production a few years ago. So here's all our cannabinoids, and the ones that we're most concerned about are the first one and the last two. So THC, and then THC, the carboxylic acid, is an inactive metabolite, and 11-hydroxy-THC is actually an active metabolite. And when I get to pharmacology, I'll tell you how all that comes about. The others are cannabinoids that may have some medical use and may not have some of the undesirable effects that THC has. Well, let's talk a little bit about history. The early 20th century, marijuana was considered, right up there with heroin. A very dark drug, as it were, only used in shady circumstances, maybe associated with musicians and the bad part of town, and then that even went on for decades. I know, and I was a kid in the 60s and 70s, that they would show you Reefer Madness, right, the movie, and everybody just smoked marijuana and went nuts and had orgies, and that's what marijuana does to you. So that obviously didn't have a whole lot of truth to it, but that was pretty much the popular sentiment for the first part of the 20th century. Now, it actually wasn't illegal early on, just like cocaine wasn't illegal early on. Heroin wasn't illegal early on. It took time for the government to get involved, and they did with marijuana. But what they also decided to do was, like everything else the government likes to do, is tax it, right? So any product that had hemp or hemp products in it, hemp derivatives in it, got taxed. And early on, a doctor could write a prescription for marijuana, just like a doctor could write a prescription for cocaine and other things and that we now consider illicit drugs. Now, there was a couple of acts that were passed that made it, number one, taxable, and then eventually it would be made illegal. But in the first part of the 20th century, that wasn't the case. Now, it was made a Schedule I drug, and I'll talk about Schedule I drugs here in a second, but so at that point, doctors could no longer write prescriptions for it, and it really was put up as an illicit drug. And that changed. In 2000, in Colorado, the citizens approved medical use of marijuana. And by 2010, dispensaries were pretty widespread. So, and this was for medical use. It hadn't been legalized for recreational use yet. In 2012, the amendment actually passed to make legalized recreational use in Colorado pretty much the status quo. And then some of the other states have followed suit. And now it's legal in California, Oregon, Washington State, Washington, D.C., and everybody's kind of following along the bandwagon, and they looked to Colorado as sort of the leader in bringing this about. And the politicians in Colorado, most of them, or at least the ones that are proponents of this, they have bragging rights, and they, go out and do talks and presentations and how Colorado made this all happen and how you all can do this as well. I kind of make the analogy to the state lottery. Back in the 70s, state lotteries were just coming about. And it was going to be a big windfall, and we were going to get all this extra money for school. And that's kind of what goes on in Colorado. They tax sales of marijuana and marijuana products, and they take in an awful lot of money. And the politicians, they like that. Now, I don't know that I'm seeing a whole lot of this money being added to the Treasury as much as sort of let's move some from here and add some to there. And that's really what happened with the state lotteries, right? I don't think the schools got any terrific improvements from the lottery system, and I don't know that we're see any huge benefits from the tax dollars taken in on marijuana sales. But that's sort of the politician take on it, and I try to stay out of politics, but it's pretty hard to hide from that one. Well, what's a Schedule I drug? Again, a Schedule I drug, you can't write a prescription for it. It's not supposed to have any medicinal use. Currently, heroin is a Schedule I drug in the United States. It's not in Great Britain. They actually use heroin as a prescribed drug in Great Britain. Cocaine in the United States actually can be prescribed for. It's used as a vasoconstrictive agent, so that really isn't the same. And for at least a couple of decades, marijuana was a Schedule I drug. No medicinal use, can't prescribe it, basically relegated to the illicit drug category. So Amendment 20 in the year 2000 is when Colorado said, okay, we're going to allow medical marijuana. And folks with debilitating injuries, debilitating illnesses, chronic illnesses, conditions that were seen to be amenable to the use of medical marijuana were allowed to use it under certain restrictions. They could possess 2 ounces and grow 6 plants, or their caretaker could grow the plants for them, and then one caretaker could actually take care of several people and grow that number of plants for all the people that he or she was taking care of. There's probably a little bit of abuse allowed in there, or at least seeping into that, but that's the way the rules were. And these are some of the diagnoses. Cancer, HIV, AIDS, epilepsy, glaucoma, I think everybody knows about. As far as diagnoses go, some of the symptoms, if you're wasting away, starvation, often due to the other diagnoses that are on the left-hand side, chronic pain, muscle spasticity, and, these are subject to some abuse, of course, and in fact, I think I've been coming to Las Vegas to work at the coroner's office here since about 2010, maybe a little bit earlier than that. And the first time I came here for that, I landed at McCarran Airport, and there's a big sign that says Dr. Reefer, right up there, a big billboard. Obviously, there's a big market out there for medical marijuana. It's probably not as big a deal now that it's legal in Nevada as well, but still, that was sort of my impression of medical marijuana. You could come up with something, go see a physician who would prescribe medical marijuana for you, and you got your medical marijuana card and went out and purchased. And this is just a long list of some of the different conditions for which medical marijuana may or may not be helpful, but you certainly could get a prescription for it. So in 2006, Colorado had another amendment out, and it was proposed that possession of a small amount of marijuana would be okay as long as you don't use it in public, and it was defeated. So that was the first attempt at legalization in Colorado, 2006, and it was defeated. In 2010, it came back to the legislature and to the public, and it actually proposed that legalized recreational marijuana, full-scale dispensaries, cultivation, all of those things would be okay under this bill, and it ended up being sort of the blueprint for legalization for other states, as I've mentioned, and it actually created a state regulatory agency, because you have to have oversight, of course, and enter in the politicians, and so manufacturing of edibles came about, and Colorado was on its way. So it finally became legalized in 2012. Medical marijuana was commercialized all the way back in 2009, but recreational passed in 2012, and then it took a couple of years to set it in motion, and January 1st of 2014 was considered the date to go live, as it were, with legalization. And basically, there are grow houses everywhere, at least in the center part of the state. There are dispensaries. They like to call them dispensaries. It makes it sound a little bit more legitimate, but basically they're storefronts where you can go in and you can buy pretty much anything, given certain requirements. The amounts are governed, and it depends if you're a resident or not a resident, but essentially this is information I gathered for the talk a while back, and it's probably outdated as far as the number of retail storefronts go and medical dispensaries, but basically every street corner in Denver, you're not very far from a dispensary. So when I say popular ballot in here, that means of the people. It doesn't necessarily mean it's completely popular, although it did pass, so it was popular enough. It legalized recreational use of cannabis for adults aged 21 years or older, and commercially it became available in 2014. And I apologize for the small print on this. It was mostly to add to your notes, but basically it gives you the nitty-gritty of legalized marijuana products in Colorado. You can grow up to 6 plants in your house. Personal use is okay, obviously. You can possess cannabis products, and as long as the products stay where they're grown, you can't be distributing. That's still illegal. And if you're 21, that's all okay. You can also give small amounts of cannabinoid products to other people. You can't use it in public, and that's kind of an issue because nobody really follows that. Although I was discussing this with some folks during the break, and you walk down Fremont Street and you can smell people using as well. But you can't go to a concert in the Denver area, whether it's outdoor at Red Rocks or indoor at the Pepsi Center, without running into people just consuming in public. And in fact, on April 20th of every year, right in our city park, they hold a big 420 celebration. And there's a huge cloud of smoke over the city park, but you can't consume in public. And basically the law enforcement looks the other way. I mean, they have other things going on. They'll make a few, just sort of exemplary arrests here and there to say, they'll say that 20 people were cited for public consumption. And on the news, you saw hundreds in the city park, consuming. So the in-public thing is pretty minimally enforced, I'd say. What they are now trying to do, as far as the industry goes, is to allow for places where you could consume in public places. Perhaps go to a hookah bar, as it were, or something like that, and consume. And they're working on that. There's also one very innovative group instituted, the Church of Cannabis, and they actually have marijuana weddings, marijuana-themed weddings, and things like that. And they also have tech's, status as a church. So all that's kind of interesting. But anyway, so as far as the use of cannabis products in Colorado goes now, it's certainly legal. It's available on every corner. If you are from out of state, you can use it while you're here. while you're in Colorado, don't try to take it out of Colorado. Denver International Airport, which is the 5th busiest in the country, basically grabs a lot of cannabinoid products on people's way out of the state. But essentially, you can use it while you're visiting, and it's become a big tourist thing. You might have seen in the news maybe a month ago or so, there was a tourist bus that was driving around Colorado, and they cited the bus for people using marijuana products in the back. That's really not allowed, although that industry was arguing, yes, it was allowed, and so we'll let the lawyers figure all that out. But, people have marijuana-themed vacations. And again, the politicians like that. I mean, it's, okay, we got tourist dollars coming in. So, some of our neighboring states aren't very happy with legalization. I know Nebraska was not real excited about it because they would have a lot of folks driving from Colorado into Nebraska carrying marijuana products in their vehicle, and they even set up some, roadside checkpoints and things like that. So my advice is, if you're coming to Colorado and you decide to, utilize these sort of services, what happens in Colorado stays in Colorado, just like what happens in Vegas stays in Vegas, right? But there you go. This is what it looks like. You can go into these stores and you can shop and, test drive things. And they actually have cannabinoid-based vendor fairs where you can go in, and they have very similar to out here, but, ours is a little more focused on forensics and death investigation. But you go from booth to booth to booth, and, one will have various types of bongs, and then the other one will have, different types of edibles, and it's big business, and it's, big tourism sort of things. This is the bottom line. Essentially, you got to be 21. You can have 1 ounce as a Colorado resident, a 1/4 ounce as a non-resident. You can grow 6 plants as a person in Colorado as a resident. You're not allowed to use it in locations that are available to the public, and again, that's never enforced. And the state will test edibles, and actually I've gotten a little better with that since a fatality that occurred the first year of legalization that I'll present towards the end of the lecture. And they established a DUI concentration. And we'll talk about the toxicology involved, but the DUI cutoff, and just like it's 80 or 0.08 for ethanol, well, for cannabinoids, it's 5 milligrams or nanograms, per milliliter of THC, of delta-9 THC, and extremely hard to enforce. And as far as measurements and things like that go, we'll talk about the toxicology. It's what the traffic investigators tell me is that they can tell by looking in at the eyes of the individual, the capillary dilatation and things like that. I'm not buying that either, but essentially, if you're impaired, you don't have to have a 0.08 to get a DUI for ethanol either. You just have to be driving erratically and impaired, and that would be the same for driving under the influence of cannabinoids. But you can imagine how difficult it might be to measure this at any kind of roadside check. And as we'll talk about later on, what sort of testing is done and what sort of results you get, or anyone's guess on the validity in some cases. Now, edible consumption is kind of an interesting thing in itself. There are some rules. You cannot have a product that has more than 100 milligrams of THC in it. And the product actually has to be homogeneous, which means it has to be, you can't have a whole bunch of THC in half of the edible and nothing in the other half. It has to be well distributed throughout the entire product. Now, I know there's a lot of Colorado folks here because I've already said hi to a bunch of you. And I know you're going to say, this wasn't popular with everybody, and I totally agree with you. This is the distribution of how the vote went. Now, if it's a presidential election, 55 to 45 is actually a pretty good thing. But 55% of the population said yes to this amendment, 45% said no, and the green area in the middle is pretty much, the center of the state, slightly east of center. Those are the counties that went yes. You can see that the eastern side and the western side of Colorado was not on board with this, and but the center of population for Colorado is pretty much what you see in green. And oh, by the way, this is where all the grow houses are located. Our major universities are all in that corridor too, between Fort Collins and Boulder and Denver and Pueblo. And so, anyway, so not everybody in the state is exactly thrilled about this. I get all kinds of phone calls from activist groups, and they want, all the data I have on marijuana-related deaths and positive toxicology, and they want me to go out and make speeches for them on, the scourge of allowing legalized marijuana and what it's doing to the kids in the schools and things like that. And I decline to get involved in that way. Number one, I don't really have a lot of data to back that up, and number two, that's not really my job. But if they want to be activists, that's great. Now, one of the things that is pretty well known about cannabinoid products is that the strength is increasing. So this is not, your parents' marijuana, or in my case, what I was exposed to in college, which was the 80s. But this is a much more potent form of marijuana. And you can see over the years how the average content has gone up. And there are now some boutique places that say that we can produce a product that's 30% THC, as opposed to the 2 or 3% that was around just a few decades ago. So the other thing is that it smells totally different. Now, I was in the military for 30 years, so I'm going to come clean with you all. I've never used marijuana. I could have been tested any day and lost my job and been prosecuted, so that didn't happen. But I lived in a college dorm, and I, had roommates and neighbors and everything, and it didn't smell nearly as bad as it does these days. If you drive into Denver, and I live south of Denver, as you approach the city, you can smell the grow houses. And that's windows up and ventilation on. It doesn't matter. You can smell the grow houses. It's a much more pungent smell. And no, you didn't just hit a skunk. That's the grow houses you're smelling in Denver. It's a much stronger product, and you can tell from the odor. Let's talk a little bit about cannabis pharmacology. And again, I try not to dumb down the lectures and make y'all feel like, I'm talking down to you, but I also appreciate that not everybody in here is a biochemist or toxicologist either. So hopefully, I found a happy medium somewhere in between, and at least you'll glean a few teaching points out of this. So the effects of marijuana, cannabinoids, euphoria, we all kind of know that, somnolence. Anybody thinking, Fast Times in Ridgemont High and Spicoli, right? Well, that's a little bit of an exaggerated sort of picture, but that's some of the effects. The eyes being bloodshot. That's, again, what the traffic detectives tell me. They can tell if you're overly impaired because they look at the injected sclera and like, maybe. Dry mouth, slurred speech, and then one of the reasons why it was first used for medicinal purposes is the appetite stimulation. And we've had an increasing number of these storefronts all over Denver as well, and I think some of the fast food chains have capitalized on that. And so you put up the dispensary, and right next to it you put Papa John's Pizza, right? So, well, there are some desirable or desired and undesired symptoms. And some of the desired symptoms, relaxation, a feeling of well-being, the increased appetite certainly for folks that are suffering from a chronic debilitating disease. There are some adverse effects. Dysphoria, that means sort of you kind of feel lost, and kind of a combination of anxiety, depression all at the same time. Fear, paranoia, we see that in some of these individuals, and I'll show you a case or two later where that came about. Panic reactions, vomiting, even though it increases your appetite, cannabinoid products can also cause vomiting, and we'll go into the cannabis hyperemesis syndrome later on. There are some objective signs. Usually the heartbeat goes up, the blood pressure goes up, but you get postural hypotension, meaning when you go from sitting down or laying down to standing up, you actually feel lightheaded and uneasy on your feet. Slowed reaction times, pretty much everybody knows about that. That's the problem with driving a motor vehicle or trying to perform your job. And slurred speech, and then walking a little bit off kilter. So delta-9 THC is the active ingredient, the main active ingredient. And it binds to plasma proteins in your body and gets carried around just like all kinds of other drugs and things that we put into our bodies. It'll accumulate in highly perfused organs, and it'll get metabolized primarily in the liver. And delta-9 THC will first get metabolized to 11-hydroxy delta-9 THC, and that's still an active metabolite. And we measure both of those. And we also will measure on standard toxicology for post-mortem testing anyway, the inactive metabolite, and that's delta-9 carboxy THC. So all of those three are typically reported out on a toxicology form. It depends on what lab you're using, but most labs will report all three of those. Now, delta-9 THC will rise very quickly after smoking for sure, and then drop very quickly, typically, after cessation of use. And the standard rule is within a couple hours. There's a lot of caveats to that we'll talk about, but essentially, the carboxy metabolite can stay for days. And so when we're looking at the toxicology report, if there's no delta-9 THC on there, they probably haven't used recently. If there is delta-9 THC, they probably used recently, but they could be a chronic user, and it's going to stay high longer than someone who's an infrequent user or a naive user. And also, in just some individuals, depending on their metabolism, it will also stay higher longer. So we can't really make a good rule of thumb and say, oh, if there's delta-9 THC, they just used an hour ago. And unfortunately, the courts would like us to say that. I get asked about toxicology all the time, even in a shooting case, right? And it's a gunshot homicide, but toxicology's there, and the defense has nothing else, so they bring out the toxicology and they say things like, well, look, what can you make of that? Was he impaired or not? I don't know. You'll have to ask somebody who was there, because I'm not going to be able to determine impairment based on a toxicology report. The most common routes of administration are smoking and edibles. There are other routes of administration, as you can see here. I'm not so sure the rectal suppository part is really popular, but it is listed in the literature. Transdermal patches. There are lotions that are made out of cannabinoid products. Vaping, as I've already talked about, is really a form of smoking, but the most popular are smoking and oral ingestion. So let's go with the most popular, the smoking, right? Basically, the bioavailability, meaning how much is actually absorbed into the body from the smoke that's inhaled, is extremely variable. Really depends on retention time, how long the person holds that inhaled smoke in their lungs, and how well the product has been combusted, and all those sort of things. How often, how many breaths, the inhalations does the individual take, and how deep are those breaths? Extremely variable. But it is a very efficient way of getting cannabinoids into your system. Basically, the lungs, by design, have tremendous capability to exchange gases and chemicals. That's how we survive, with oxygen and carbon dioxide being exchanged. Well, when it comes to taking things into your system, that's probably one of the best routes of administration. So it gives a fast onset of effects. gets into your bloodstream fairly quickly, and therefore is pretty much the preferred method. And you can titrate your dose somewhat, right? You inhale more, you hold it longer, you take more inhalations. So this is basically showing you the concentrations of the three chemicals we talked about, the main cannabinoids based on inhalation of smoke. And, up very quickly with the inhaled with THC, and then it drops very quickly, and then you have your metabolites that don't go quite as high, but stay around a little bit longer. What about smoking versus oral ingestion? And this is one of the problems that comes into play with cannabinoid usage, and this is how some people get into trouble, and this is how I'm able to present to you later on a fatality case. Essentially, there's a big difference between ingesting and inhaling cannabinoids. And one of the ways the toxicologists have looked at this is to say, well, generally you get a higher amount of that 11-hydroxy metabolite than the delta-9 THC relative when it comes to oral ingestion relative to smoking. So you might be able to tell that it was a ingested product used instead of an inhaled product. And so the toxicologists tell us that that's possible. I've not used it, and truthfully, it doesn't really matter in my line of work how they got the cannabinoids in the system. So, but it's interesting food for thought, pun intended. Here's three methods of getting cannabinoids into your system: injection, oral, and inhalation. And you can see that, obviously, if you're injecting something right into your bloodstream, that's going to be very rapid, and the body's going to be able to then work on it and clear it. Smoking, inhaling, fairly rapid, and then ingestion, eating, going to take a lot longer to get into your gastrointestinal tract, get acted upon, and get into your bloodstream. So when you use an edible, the bioavailability is a little bit tighter, 10 to 20%. Digestion's not a perfect mechanism as far as breaking down products and getting them into our system. But so the absorption's kind of variable, and the stomach will degrade some of the product before it ever gets into your bloodstream. Essentially, compared to smoking, there's this long delay in onset, and that's what the users don't quite understand very well sometimes. And lower peak concentrations, and then an extended duration of the pharmacological effects compared to smoking. So this is where the actual metabolism takes place in your liver. That's sort of a good attempt at a liver, I suppose. The cytochrome P450 complex, which actually breaks down a lot of chemicals in our body, takes care of cannabinoids as well, and you go from the delta-9 THC to the 11-hydroxy THC, then to the delta-9 carboxy THC. And for those of you that insist on seeing chemical structures, here you go. There's always somebody, right? Well, it might interest you to know that just like when it comes to opioids, we all have cannabinoid receptors in our bodies, whether you've ever used cannabis products or not. If you've ever thought of it, you probably assume that might be true anyway. I mean, there's these receptors in your body for various chemicals that your body has never seen, or in the case of opioids and cannabinoids, it's because we produce endogenous products that are in those same drug families. And so, just like you have, if you're a marathon runner and you get that runner's high from endogenous opioids, well, there are endogenous cannabinoids in your system as well. So there's these receptors around that will act on the cannabinoids, whether they're endogenous, meaning produced in your body, or exogenous, meaning you've gotten them through use. And these receptors are found in the brain, no surprise there, some of the lymphoid organs for the immune system, and heart, kidney, and various other organs. And they've divided them into CB1 and CB2, and I only give you this as just to kind of general education that, there's these different types of cannabinoid receptors, and some of them have more activity in the brain, and some of them have more activity in the immune system. And that's really the take home there. And these cannabinoids, receptors respond to exogenous cannabinoids a little bit differently than endogenous cannabinoids, and they even respond differently to some of the exogenous cannabinoids. And this is where maybe the medical aspects come about. If we can sort of take advantage of the cannabinoid receptors that are helpful without using the cannabinoid receptors that perhaps have undesired effects, then we can exploit the medical uses of the product. And I'll give you a little picture. Just basically, this is a nerve synapse, and essentially this happens with every type of chemical that interacts with the nervous system in the body. It's all done through neurotransmission, and there's some secondary messengers and things that, for those of you that have had biochemistry, you wish you had forgotten, or maybe you have forgotten. But essentially, that's how these chemicals act on the body. Well, let's talk about postmortem toxicology with cannabinoids. For a while, it was pretty much ignored. We didn't even test for cannabinoids. It was thought to be, number one, the testing methodology was a little bit more in its infancy, and it was thought to be kind of a waste of money. I mean, why bother? Well, now I think it's on pretty much everybody's standard postmortem testing regimen. And as I mentioned, pretty much most labs will report out delta-9 THC, the 11-hydroxy, and the carboxylic acid metabolites. Now, there's some postmortem redistribution that happens with all kinds of drugs. So the levels you might get at the time somebody actually dies versus what you might get 12 hours later when the autopsy is performed, or maybe 24 hours later when the autopsy is performed, may not be the same. And that's really with all drugs for the most part. But there has been some debate on postmortem redistribution with cannabinoids, and there's some very famous or very high-level toxicologists on here. Dr. Nick Lemos and then Dr. Holland have on opposite sides of the coin on this. One of them says that cardiac blood will have artificially higher levels than peripheral blood. The other one says peripheral blood will have artificially higher levels than cardiac blood. And you can see if the experts, the PhD toxicologists, can't agree, it's pretty hard for the pathologists and the death investigators to get on board with this. So again, there's two different trains of thought here based on which papers you read. Some say postmortem redistribution causes the peripheral blood to be preferred, and others say that it causes central blood to be preferred. This is the historical wisdom, meaning, and that's in quotes because probably not true, but thought to be true for quite a while. The little graph insert there is actually 5 different subjects that were given a specific amount and actually a computer-controlled inhalation of a cannabis product. And even they were all over the board as far as their testing went. But conventional wisdom said that the THC drops to near zero a few hours after the last use. That's that delta-9, right? So you're saying, oh, it's zero, hasn't used in a while, or it's there, must have used within the last hour or two. And that if it's at 2 or 3 or 5 or whatever, they probably had pretty recent use within the last 6 hours. But the toxicologists that have looked into this have said, nah, it's not really true, actually. And basically, you'll typically get back to baseline a couple hours after smoking, but in a heavy smoker, that delta-9 THC might be very high still, several hours after use, maybe 10 hours after use, and in one study, days after use. And so that kind of throws that whole hadn't used recently out the window. Well, let's get out of the toxicology realm and talk a little bit about usage. And I'm just going to give you an idea of what's going on in the state of Colorado. So, This is current marijuana use among Colorado adults, and it's a couple years old, but just to give you an idea of right around when we were doing legalization, this is divided by age group. And you can see it didn't change much between the 2 years. Now, I have to put a caveat on here, or a disclaimer. This is all self-reported information, so, you really don't know exactly what you're getting here, but this is what the health department has. And then frequency of use. Are they using every day? Are they using a couple times a week, or very infrequently? And these are adults. And then we did some division by race and by other types of demographic data. And you can see it did change from year to year in certain groups, but again, all self-reported and just FYI type information. Sexual orientation, again, divided into self-reported heterosexual and self-reported other. This is kind of interesting. This is where those the activist groups get on the medical examiners and coroners to give them their data, because they want to say, well, look, it's ruining our school children. And what is kind of interesting is how early, and maybe most of you, if you're parents of kids in this group, already know the risks of a seventh grader or eighth grader or even earlier getting exposed to using some of these products. And obviously, usage goes up as expected as the kids get older. And then dividing the adolescents by race and ethnicity. And by sexuality. Again, self-reported data. Well, what's new about cannabis is, well, it's legal in Canada now. So those folks north of the border are experiencing the same things that we're experiencing in Colorado and the other states where it's legal. Typical grow houses. We actually have, I work for the health department. Medical examiners' offices come under various, as they say, everybody has to have a boss. Sometimes it's public safety, sometimes it's the health department. If you're lucky enough, you get a standalone office, but I pretty much inherited a situation where I work for the health department. And there are colleagues of mine that have entire teams that go out and do these grow house inspections, and most of the time what they're looking for is pesticides and other things that might be hazardous to the consumer. Not so much any kind of legal, illegal activities, but more of, is this healthy? Is this what we should be putting out in these storefronts? Well, people are creative by nature, and so extraction methods have become a little more sophisticated, using different solvents, and this is where we get those fires. And we've had several in the Denver metropolitan area over the past few years, and there have been people injured and killed due to these extractions that they're using heat sources and different solvents, which are universally flammable for the most part. So these are edibles from when I was in college, right? Somebody laced the brownies with marijuana, and everybody felt a little funny and got giddy and laughed, and that was that. These are the edibles that are out there on the market. And it's really hard to tell the difference on some of these. I mean, pot tarts, right? And, instead of a Klondike bar, you get a Cronkite bar. And you might imagine how difficult it would be to keep a kid away from these things. I mean, if they're not in the package anymore, those gummy bears look just like everybody else's gummy bears, and the cookies look like cookies, and the candy looks, like the regular candy. And that's where the pediatric problem comes about. And then there's different other edibles. You can use butters and oils and spreads. And so if you're ever visiting Denver and you want to go shopping, these things are all available out there at the stores. Lollipops, different kinds of candies. The wrappers even look very similar to, the Kit Kat bars and things like that. These are courtesy of the DPD folks. So what's the problem with edibles? Well, twofold. One, I've already talked about, the metabolism, and we'll get a little more specific on that. The other is serving size. The way these things are marketed, one candy bar is supposed to give you like 10 or sometimes 15 doses. What American eats 1/10 of a candy bar, right? This doesn't happen. Now, if you do read the directions, the serving size for a regular candy bar says, eat the whole candy bar. Here's how many calories it is. That's how much time you're going to spend on the treadmill working it off. The serving size for the edibles says, this is supposed to give, either 10 people or one individual 10 different experiences. And that's just not how people consume things usually. So I did mention that an edible product can't have more than 100 milligrams of THC in the whole item, and it's supposed to be evenly distributed, so each dose, as it were, should be maybe like 10 or so. And if you read the fine print, that this cookie is made to be broken into 6 pieces. Well, who's going to eat a little tiny bit of the cookie? It's just not going to work like that. The other thing is, and this goes back to the metabolism thing, people who have used cannabinoids are used to smoking, and they're used to a rapid onset and getting that, feeling of well-being or whatever pretty quickly. Edibles don't work that way, as we've talked about. It takes a couple hours. The digestive tract works on what you've put into your stomach. And so what happens is the person gets impatient. I don't feel anything. And they have another one. And I still don't feel anything. And then they have another one or two. And so that's how these folks get into trouble with the edibles as far as the adults go. The kids, they get fooled by the product. It looks like candy. So the current regulations, again, you can only have 100 milligrams of THC in any product. Not supposed to be designed to appeal to somebody under 21. I'll let you guys be the judge. The container is supposed to be child resistant, and you must leave it in the child resistant container. Well, once you bring it home, you're going to do whatever you want to do with it, unfortunately. And no mass marketing campaigns. You can't, come out and get you can't put ads out that say, get your gummies that are laced with THC. So let's talk about the pediatric exposures. Dr. Sam Wang is over at Children's Hospital in the Denver metro area, and he has put out a couple of papers. Initially, just a few patients with exposure, and they had positive urine tox screens, and they actually behaved like they were overly sedated with THC products. And some of these most of these in this initial group actually had a medical marijuana card. These were just, overreactions and overly sedated, and actually had to be hospitalized for consuming THC products. And then Sam moved into another group with that were even more severely afflicted, and then produced a very large-scale paper with almost 1,000 subjects. And some of them they were exposed to non-criminalized sources of THC or decriminalized sources, and then others were just basically illegal. And this is just the kids getting into the product, right? And several of these kids had to be put in the intensive care unit. A few of them had to be put on ventilators. None died. That's the good news out of this. But most of the symptoms lasted less than a day, and a lot of these were encounters with these edible products. The kids thinking that they're just eating candy. So I've got a few slides here with rate of hospitalization, and I think really the take-home message is, for Colorado, once things became legalized and widespread, the numbers in the emergency room have just taken off. You know, there's this sort of pre-legalization. Yeah, we saw a few hospitalizations, but as legalization occurred, the emergency room doctors are very, very busy. This is probably the most graphic. So, and then there's year-to-year changes, up 20, 30% each year for the last several years with emergency room visits and hospital admissions. The Poison Control Center folks are much busier. They get a lot of phone calls due to these inadvertent exposures to edibles for the most part. Some of it is not from the edibles, but most are. All right, how about cannabis hyperemesis syndrome? So only a few of you have actually heard of it. Anybody have a death? Okay, we've had one in Denver. I know there's been a couple in Colorado, I think. And then there's a series of 4 or 5 reported out of Canada, even before legalization. Yeah, I like the picture, right? The best description of this would be perpetual morning sickness, okay? Cyclic vomiting, you know, and it's all related to chronic cannabis use. None of these people are once a week type users. These are daily users. They tend to have abdominal pain, cyclic vomiting. They're often worked up initially for things that aren't related to their cannabis use. Maybe they think they have food poisoning or some sort of functional GI disorder giving them the cyclic vomiting, but it's the cannabis use actually. And interestingly enough, they find relief with hot showers or hot baths. So that'll cinch the diagnosis. As I was an internal medicine resident my first year, and that's where you say, okay, I can make the diagnosis, the hot showers, you know. Here's a couple of folks, and I'm going to have to put I'm going to come over here and read it off of here. It's just bigger. But essentially, these are some individuals that have cannabis hyperemesis syndrome. And so you can see the age of onset of their use. You get anywhere from mid-teens to later than that. How old were they when they started developing the cyclic vomiting? Okay, so 22, 20. I even have got this fancy pointer here. And this is how long the duration's been going, and this is years. Okay? And if they stopped, the symptoms went away. You're cured if you stop using cannabis on a daily basis. And so, you can see that, okay, this person, was well for, 9 months and 2 years, after stopping. Well for 4 years, and then 2 years again because stopped, started again, and stopped again. And the one at the end here, not going to stop. Just, I'll put up with the cyclic vomiting. So, so the key is chronic cannabis use, cessation will stop the problem, and then they all found relief with these, you know, warm shower, hot showers, hot baths. The publications have increased the last few years over CHS, Cannabis Hyperemesis Syndrome. Doctors always use acronyms, right, and things like that. So it's becoming something that we're more aware of, probably resulting in a diagnosis being made more often, so maybe a little of a self-fulfilling prophecy there, but in the past, many of them were written off as functional GI problems. One large-scale study, you know, they eliminated people that only had one episode or had an organic cause of hyperemesis or were lost to follow-up or something like that. But basically, the bottom line on here is they're just identifying more and more of these cases. So let's talk about a case I had in Denver recently that actually one of my colleagues did the autopsy on. This is a 44-year-old female, and she was found unresponsive on the floor of the home that she shared with her mother, and she was a daily dedicated cannabis user, and she also had some GE, gastroesophageal reflux, and other sort of functional GI issues, so that clouded things a little bit. Now but this diagnosis had been made a while ago on her clinically, and she had actually developed pneumonia in the past due to her debilitation from this cyclic vomiting. And she would have frequent episodes of abdominal pain, and it was all pretty much chalked up by the clinicians to her Cannabinoid Hyperemesis Syndrome. And she was found, as I said, by her mom, and she was pronounced dead and brought to our facility, and she, not surprisingly, also had pneumonia on histology. She was a little bit obese, but her toxicology showed what we've been talking about for the last hour. Basically all three of the major analytes tested for, the 11-hydroxy, the delta-9 carboxy, and then the delta-9 THC. 13, by the way, is almost 3 times the 5 for the driving, but again, that's pretty squishy as far as cutoffs go. But a little bit of Benadryl on board, and that is just a little bit. That's a very low amount of diphenhydramine, and then positive for caffeine. So in these cases, it's always good, if you ever hear of somebody's, vomiting a lot, you want to check their electrolytes of their vitreous fluid. And it shows a dehydration pattern. Her sodium is up, her chloride is up. It looks like, based on the best you can tell from vitreous analysis, her kidney function looks okay. Glucose at 64 is, usually it's 0 in a non-diabetic, but it can be anything up to 100 in a non-diabetic for the most part. So basically she was signed out, and then we did PCR testing because of the pneumonia, all the possible viral pathogens that our hospital would let us get away with testing for, and they were all negative. So essentially she was signed out as, her pneumonia, but in the contributing causes, the Cannabinoid Hyperemesis Syndrome was put down as a contribution. There's some other fatal cases that have been reported in the literature. There's a series of 3 cases that are about to go to publication. And one was initially thought to be food poisoning, and they basically then settled on Cannabinoid Hyperemesis Syndrome. One of them had been going through nausea and vomiting cycles for 8 years, similar to some of those ones I showed you early on. The electrolyte patterns at autopsy varied on all of them, but they all had positive tox for delta-9 THC. This is how you would treat somebody before they make it to the coroner's office. Benzodiazepines, supportive care, capsaicin cream, that gets into that hot shower thing, right? And the bottom line, though, is they have to stop using cannabinoids, and some of them just aren't willing to do that. Well, what we did, and this is always nice work if you have a fellow, we have a forensic fellow in our office. That's somebody who spends a year, he's already a pathologist or she's already a pathologist, and they spend a year of just doing forensics, and then afterwards they can go out and practice on their own. So if you have a fellow, you have to put him to work. And so at the last American Academy meeting, our fellow presented this information. Essentially what we did was we went a few years before legalization and a few years after legalization. And all we did was go through the cases, and we pulled the ones that were positive for cannabinoids, and then we divided them by manner of death. And we just wanted to see if there was any difference in how the percentage of folks that were positive for cannabinoids before legalization and after legalization based on manner of death. And all the cases were reviewed by forensic pathologists to determine manner. In our office, it's the forensic pathologist that determines manner. As the chief medical examiner, I can certainly overrule that, but each individual pathologist will assign manner to their cases. And as you all know, we've got our different manners, right? Natural, accident, homicide, suicide, and then at the end of the day, if we either can't figure out a cause of death or can't divide it to one of the other 4 manners, we go with undetermined. So, and here's our results. A little over 3,000 cases were reviewed, and we had about a little over 50%, 55, 60% were pre-legalization, and the rest post-legalization, and about a fifth and a little bit more were positive for cannabinoids. And this is a division of manners of death in our office, and probably looks fairly similar to most medical examiner jurisdictions. Denver, even though we have over 700,000 people at this point, relatively peaceful city, and this is somebody who grew up in Chicago and trained in Baltimore, so that's my relative, point of view. I mean, if we get 50 homicides in a year, that's a big year. So our homicide rate, and that's what makes it an attractive jurisdiction to cover. We have a tremendous suicide rate, though. That I don't quite get. You live in paradise, and the sun shines a lot, and yet we average some weeks of suicide a day or more. So accidents, these are non-traffic related accidents, and that would include drug overdoses most of the time, the non-suicidal drug overdoses. The pre and post legalization up 3% after legalization. So not really very statistically significant. Traffic related accidents up 12%. Again, as I said in the first slide or two, it's hard to say causation. This is correlation, right? They're dead. They're in your office getting an autopsy. They may have been a driver, a passenger, or a pedestrian for traffic related. And they're positive for cannabinoids. Do I know if they were impaired at the time? And again, if they were the passenger, maybe that wouldn't matter much. If they were a pedestrian, maybe it would matter much. I had one yesterday, and I couldn't get in until late last night because some individual decided to try to cross I-25 at midnight and only made it halfway. And he certainly will come back positive for ethanol, probably have cannabinoids on board as well. So certainly you can be impaired and be the victim of a traffic mishap. Well, this is self-reported data, and basically the first couple years of legalization, there's 2 to 3% of folks that will actually admit to using cannabinoids while driving. And those are just the ones that will admit to it. And actually, I know from just driving around town and following somebody, you can actually tell if the car in front of you is using enough, it'll come in through your vent system or in your window, and you can have a pretty good idea what's going on in that vehicle. Natural deaths up 5%. Suicides up 21%. This is probably the most striking increase for our data poll, was that 21% more people tested positive for cannabinoids after legalization than before legalization that were assigned suicide as a manner of death. Homicides actually went down. So the number of folks who were victims of homicide, less of them had cannabinoids on board after legalization. And undetermined was a flat line, no change. So here's a summary of our data, and again, I just gave you all those numbers, but and then the prevalence of Colorado adults who drove a vehicle when using marijuana in the past 30 days didn't statistically change at all. So let's go into a couple of fatalities to finish up our session. This is probably the most famous. This occurred shortly after I arrived, and I was wondering if this was going to be maybe the beginning of a bunch of cases for us, but it turned out to be pretty much the only one I have to offer you. This was a 19-year-old African male. He was actually from Africa, and he was up at the University of Wyoming with a bunch of other students, and they were all exchange students, and it was spring break. And what happens at spring break? The whole campus emptied out. And these folks, they're stuck. I mean, they're not going to fly back to a foreign country usually for 1 week or less. So they said, let's go down to Denver. I hear they have legalized pot now. We should try that out. So they came down to Denver, and they went to a dispensary, as it were. And this young man had no significant medical history. His parents actually flew in, and I met with them, and he had no psychiatric history. I mean, everything was pretty much, negative. as far as history goes. Well, the sales clerk, from what we understand, gave very explicit instructions on how to use the edible. They bought these cookies, the 6 doses to a cookie sort of thing, and he ingested 1 piece, like he was instructed to do. And then about an hour and a half went by, and he said, nah, this isn't really doing it for me. And he decided to eat the whole rest of the cookie. And within a few hours, he began to have erratic speech. His behavior got almost violent, hostile. He tore you have those paintings in your hotel room often, the, 5 for $1 ones you can get, and they tore them off the wall. And this was one of those places that had an inside balcony, so you can look down from the 5th floor to the lobby. And he went over from the 4th floor balcony all the way down to the lobby without using the elevator. And he died. He was dead at the scene. Just to remind you about the smoking versus oral uptake. And here's his toxicology. And all we had on him, we couldn't get peripheral blood. We got chest cavity blood. And it was 7.2 for the Delta 9 THC and 49 for the Delta 9 carboxy THC. His urine was positive, no surprise. He was signed out as multiple injuries due to a fall from height, and the manner of death was an accident. We did not make this a suicide based on our discussions with his parents, and probably the contribution from what I think was the cannabinoids on this one. This one's made national news. If you watch reruns of Nightline, it's on there. This is a gentleman who blames shooting his wife on using an edible. And I actually did the autopsy on his wife, so I have no knowledge of what his toxicology was. But he was 44, and his wife calls 911, and it was a long call. And the reason it makes the news is there was some delay in the police getting to the residence. I won't go into that, but essentially, he was talking erratically. He was talking about the end of the world. He wanted somebody to shoot him. He wanted his wife to shoot him, and there were kids in the house too. And you can hear the kids in the background on the 911 call. So it's a pretty frightening call. And the wife informed the 911 dispatcher that her husband had just retrieved the gun, and then you hear a gunshot, and she ended up in my office for an autopsy the next day. And the husband reportedly confessed to shooting his wife, and he said that right before he started behaving erratically, he had consumed a Karma candy orange ginger hard candy that had THC in it. And there was a receipt for that product there at the scene. Now there's a few other non-fatal outcomes. Again, these sort of show the perhaps cause and effect of erratic behavior associated with consuming these edibles. Both of these were naive users. Both of them resolved their problems after time, but there is the possibility then of, with these edibles, having this erratic behavior, and if you're lucky enough not to be near a balcony where you can go over the side and fall from height, you'll survive perhaps. Now there's a lot of trauma associated with THC that's documented out there in various jurisdictions, and as I mentioned, we really don't know about these motor vehicle crashes, whether there's a cause and effect reaction, but these are a couple other cases from Colorado. Male rolls an ATV, and he actually has a significant THC concentration on board. One of the things that's interesting about this one is, though, if you look at his admission blood versus his postmortem blood, there has to have been postmortem redistribution. Because I don't think the hospital was giving him any more cannabinoids, between the time they drew his blood and the time he died. So this just shows you how it's very complicated to draw significant conclusions from not only from the test results, but then try to extrapolate that to behavior, which is what they want to ask me in the courtroom. Here's a pilot, and no, you should not be using marijuana products and trying to fly an aircraft, but he did, and he again, his post-mortem blood shows significant changes in or differences between his pleural cavity blood and his femoral blood. Gunshot. I'm giving you all flavors today on these, but this is a 23-year-old Oklahoma man who came to Colorado, and they purchased, he and his cousin purchased some marijuana candies, and probably not a good idea to be playing with a firearm while you are intoxicated with any kind of intoxicant, but they decided to just initially get one piece of candy, but then over the course of time, they each consumed 3 more pieces of candy, and essentially he became nonsensical and acting erratically and shot himself. So I would rule that one a suicide every day of the week. I don't know what that coroner did, but to me firearms are inherently dangerous, and I rule very few or almost no accidents when it comes to firearms, but that's a topic for a different lecture. Yeah. His actions resulted in his death, and that's how I approach firearm deaths. But anyway, this was a sharp force injury one, so I want to feel inclusive here, right? This is a 18-year-old who smoked marijuana and with a friend and became wild and stripped off his clothes and ran into the apartment and stabbed himself numerous times. Again, that one's pretty self-evident suicide, but you could say he was intoxicated and maybe not of right mind, but his actions resulted in his death. So, and that brings us to a question part. Got I think 5 minutes left, 8 minutes left, something like that. Yeah, in the back. Well, I can't hear you. Can somebody act as a repeater for that, or? Well, I'm not a toxicologist. I defer that to those that have a lot of expertise in the area, and I usually call my friendly neighborhood toxicologist when I have a question. But post-mortem redistribution occurs with almost all drugs. It's characteristic with to be excessive in some drugs and not as excessive in others. As far as cannabinoids go, I think I demonstrated 2 expert toxicologists were at opposite ends on that. As far as which blood was preferable to test, but I think it's safe to say that post-mortem redistribution of cannabinoids does occur, and so interpretation of your results should be done with some caution. And if a question comes up, call your toxicologist. That's what I do. Yeah. Do I contribute any of the military? You can't use it if you're in the military. You will be tested. So, no, actually, I don't think so. What I do, and this has been borne out recently more so by the health department, maybe even the popular media, we have a large homeless population, and if you interview some of these people, they've come to Colorado because pot's legal. That may be something, because I do autopsy a fair number of transients and homeless. Hadn't really heard the military angle. I'm curious, why would you think military would use cannabinoids more than non-military? Oh, I'm sorry, the suicide rate. Gotcha. Denver doesn't have a base, and so if they're at home or in their barracks, they don't come under my jurisdiction. There's a couple of coroners in here that, well, there really isn't. The military bases would be down in El Paso County and Arapahoe, I guess. No, I guess the retirees maybe is what you're thinking, perhaps, folks that get out with PTSD and things like that. I see a fair number of those, I have to admit. So that's, okay, I'm sorry, I thought we were talking cannabinoids still. Yeah, well, a good topic for another lecture, the suicide rate, but perhaps that contributes we do have a fairly high retiree population, and many of them suffer, post-traumatic stress syndrome and other afflictions of being in combat.
Is there a positive correlation between mental illness and fatalities?
Is there a positive correlation between
mental illness and fatalities?
Mental illness and fatalities. Yes, I think every medical examiner, coroner in the audience would probably agree with that. Certainly, most of us were trained that just having severe mental illness, such as schizophrenia, is a correlation to early death. And in fact, I trained in Baltimore, where if that's what you had as a diagnosis, often, and that's all you had, that would certainly be used to contribute to the death. Certainly, mental illness along the lines of depression and bipolar disease is strongly correlated with death. So,
with the use of higher THC MJ.
I'm sorry, I can't hear you from.
With the use of higher THC MJ in relation to.
Probably more of a clinical question. Are we seeing people with mental health issues using cannabinoids more? That would be something that wouldn't come under my scope of knowledge, probably. I have to pass on that. And I apologize. It must have been the concert the other night. I'm still kind of, I was at Journey and Def Leppard, where everybody was not smoking in public. Anything else? Yeah. That's a good question, and so I guess what you're saying is, can you overdose on? Well, yeah, you really. I have yet for somebody to show me, and maybe some of the other medical examiners. And I see head shaking here from Atlanta says no. I have yet to see a pure cannabinoid overdose. It's really, and unlike ethanol, which we all know, that's the difference between a accidental overdose and your chronic alcoholic is, it's pledge night at the fraternity and the kid comes in with a 0.45 ethanol level. But I have yet to see a case in the literature or in a practice where pure cannabinoid overdose. Now, cannabinoids are often along for the ride with heroin and cocaine. And Denver actually doesn't have, we're a little bit blessed, this is off topic, but we're a little bit blessed by, we don't really have a opioid crisis as much as meth has never left, and it's back with a vengeance. We have more methamphetamine deaths than we have heroin deaths in Denver. And often there's cannabinoids in there as well, but pure cannabinoid overdose, I have yet to see.
All right, well, thank you, Dr. Caruso. I hope everybody learned something.
Great time.